Thank you, Dr. Tuhin, for accommodating this to talk a little earlier than the beginning part of the session. So we are going in a reverse order. I will be talking to you about visual rehabilitation in unilateral burns cases. पीछे जाना है. Yeah. So my subject is late visual rehabilitation in unilateral ocular burn cases by different modalities of treatment. As we know, unilateral chemical burn sequelae would be PARAS formation, symblepharon, corneal stromal scarring and thinning, fornical shortening, restricted eye movements due to subconjunctival fibrosis, total or partial limbal stem cell deficiency, at times keratinization and loss of an eye. So we need to decide the strategy to tackle the issues which may be directly involved with the visual and functional outcomes. We all know that limbal stem cells are responsible for the regeneration of corneal epithelial cells and the maintenance of the integrity and transparency of the cornea. Destruction of these limbal stem cells or limbal stem cell niche or both can lead to limbal stem cell dysfunction and limbal deficiency. Limbal stem cell deficiency results in delayed epithelial wound healing, recurrent epithelial erosions, and loss of vision. Fortunately, limbal stem cell transplant can restore normal epithelial phenotype and re-establish stable corneal surface. In patients with unilateral limbal stem cell deficiency, the healthy fellow eye can act as a source of donor limbal stem cells, which makes the procedure autologous and obviates the need for any systemic immunosuppression. However, in bilateral cases, one can use the tissue from another person, making it an allogenic tissue with its own source of issues to be addressed post-surgery. They would need systemic immunosuppression kind of lifelong. So these are the clinical pictures of limbal stem cell deficiency. They present with conjunctivalization of the cornea or PARAS formation, recurrent epithelial breakdown, and inflammation of the ocular surface, loss of transparency of the cornea leading to impairment of the vision. If we look at the causes of limbal stem cell deficiency, almost 80% are contributed by chemical burns in unilateral injuries. So if we look at the clinical pictures, unilateral chemical burns can present with total limbal stem cell deficiency, with central corneal scarring, with less scarring, sometimes with partial limbal stem cell deficiency, as you can see here in this picture, at times with symblepharon formation with partial central corneal stromal haze. And here you can see that there is a shortening of the fornices as well, and sometimes very significant fibrosis leading to symblepharon. This is something unusual. Anyway, I just like that. We look at the algorithm for management of limbal stem cell deficiency. If we see that, the primary focus for treating any patients is you have to control the inflammation, and then you can divide them into partial limbal stem cell deficiency and total limbal stem cell deficiency. Here in this particular talk, we would be focusing on basically the unilateral chemical injuries leading to limbal stem cell deficiencies. As you can see here, they can be treated by various means. If it is, some can be treated with medical management. If they are in the initial part, they can be treated with just an AMT at times, or a symblepharon release and conjunctival autograft, while the ones which have limbal stem cell deficiency, significant limbal stem cell deficiency, would require further management in terms of conjunctival limbal autograft, SLET, or CLET. So let's look at the limbal transplantation techniques. The conjunctival limbal autologous transplantation was traditionally popularized in 1989 by Kenneth Kenyon and Professor Sang. In this technique, two large conjunctival limbal lenticulae are harvested from the superior and inferior limbus from the healthy eye, and they are directly transplanted to the affected eye. Unfortunately, this is known as CLAO. This is known to be associated with complications like iatrogenic limbal stem cell deficiency. But this procedure has the longest track record, and it has been shown to be successfully restoring the corneal epithelium in approximately 75% of the cases. If we talk about CLET, this was this cultivated limbal epithelial transplantation was popularized by Pellegrini and group in 1997, and here they used 2 millimeter by 2 millimeter limbal biopsy from the donor eye, which is expanded ex vivo, and then for about 2 weeks, and then it grows into a sheet of epithelial cells and then transplanted onto the surface of the affected eye. But though it has minimized the problems of clow, cell expansion necessitate a clinical grade laboratory and lot of regulatory approvals, which was still and is extremely expensive to build and maintain. So then in 2012, Sangwan and all, et al., they described an innovative technique of simple limbal epithelial transplantation, which is also known as SLET, which combined the advantages of clow and clet while avoiding the limitations of both the approaches. Since then, SLET has become the preferred technique of limbal stem cell transplantation. We'll look at the video in a short while. Here, what is done is 2 by 1 millimeter limbal tissue is harvested from the donor eye, and then it is cut into pieces and transplanted onto the recipient eye in terms of 8 to 12 pieces, and then it slowly grows over the cornea. Several modifications were popularized, like customized slit sandwich technique combined with conjunctival autograft and combined with MMG when there is lot of symblepharon formation or if there is paucity of conjunctiva. A lot of papers are there about the success of simple limbal epithelial transplantation, and this was a multi-center trial where they looked at, that the success was much more when there was no symblepharon as compared to the patients who had associated symblepharon. The other group also looked at autologous limbal stem cell transplantation, a systematic review of clinical outcome with different surgical techniques like clow versus clet and slet. And they looked at and they realized that, the autologous limbal stem cell limbal stem cell transplant for unilateral limbal stem cell deficiency showed anatomical and functional success rates of 69% and 60% respectively without any serious adverse events in the donor eye. And the anatomical and functional success rates of SLET was 78% and 68.6%, and clow was 81% and 74.4%, and they were comparable and significantly better than those of clet. So obviously these two techniques are much more popular in the clinical scenarios. They also looked at the economic analysis, and it was if we just analyze that in broad terms, the cost of SLET is approximately 10% of the cost of clet for adults and 8% for the children, as you can see here in the bar diagrams which are displayed into the slide. So to simplify that, whenever there is conjunctivalization in the peripheral part with partial LSCD, there is no need of SLET, or one can go ahead with conjunctival autograft. If there is conjunctivalization of the peripheral cornea plus central corneal superficial stromal haze, one can decide for CAG, conjunctival autograft, and SLET. And if there is a total LSCD but not much of a central corneal scar, SLET would be a good option. So this is a very pictorial picture showing where we should use SLET and CAG and where we should not do SLET at all. We look at the clinical case scenarios. This is a 10-year-old male who presented with symblepharon with restricted eye movements, as you can see here in the clinical picture on the right-hand side down. And he required a symblepharon release, PARAS resection, and because this was not involving rest of the limbus, we continued with clow, that is conjunctival limbal autograft. A small amount of limbal tissue was taken, and you can see that in the clinical pictures here, that the limbus is reconstructed very well. This was a case of bilateral acid injury, but one eye was less affected than the other, and in one eye, the eye which was more affected, he developed PARAS formation, as you can see here in the clinical pictures. But since he had a bilateral injury and this was relatively a limited involvement, we decided to go ahead with the conjunctival autograft rather than doing anything. So he underwent that particular procedure, as you can see here. And you can see that the cornea has become very clear and his vision improved from 624 part to 69 part, and the eye has been very quiet in a couple of weeks' time. So you can choose the procedure accordingly. This is a very recent case, right eye of bilateral acid injury patient, responded to bandage contact lens and medical management initially, but later he developed localized limbal stem cell deficiency with recurrent, you can see the hemorrhagic areas also, recurrent redness, watering, and pain. Here again, it was a bilateral, but less affected. The other eye was less affected. We decided to take the graft from the same eye, and that was taken from the supratemporal area, and it is transplanted here, as you can see here. And these are the 2 weeks follow-up pictures of the same eye. So he underwent PARAS resection plus just the conjunctival autograft. We did not take limbus. Here we took the conjunctival graft 2 millimeter away from the limbus so that not to jeopardize the stem cell niche of the same eye. as you can see here in the marking areas. This was another case where you can see a patient of Lyme paste injury with very severe symblepharon formation, and almost the lower lid is attached to the limbus, to the bulbar sclera, and only 1 to 2 clock hours of limbus is free of conjunctivalization. He underwent pannus resection with slut. As you can see here, the pannus is resected all throughout 360 degree. This is a donor eye from where we are taking 2 by 1 millimeter, 1 clock to 2 clock hours of limbus. First, we mark the conjunctival areas, and we harvested 2 conjunctival grafts. And this is the area where we are taking the dissecting the limbus into the cornea, and this is the limbal tissue which is harvested. This area, the donor area, is closed with fibrin glue and a bandage contact lens. And now we are back on the recipient eye, and you can see that first we apply the conjunctival autographs, covering the area where there was significant amount of symblepharon formation, the lower lid part. So after both the grafts are applied, an amniotic membrane is applied all over the surface to allow the limbal pieces to be placed onto the cornea eventually, so that the amniotic membrane works as a basement membrane for those limbal tissues. You can see here it is very well fixed. And then now the limbal biopsy tissue is divided into almost 8 to 10 to 12 pieces, and then it is placed in such a manner that you have 2 circles, and then that is fixed onto the cornea with the tissue adhesive fibrin glue, both the components one after the other, and then a bandage contact lens is placed. So these are the post-op pictures. You can see that pre-op and post-op, the patient improved very well. This is the final, the donor eye, and on the left-hand side, the recipient eye. The ocular surface has been stable for past 5 years, and BCVA improved from 630 to 69 part, as you can see here. This is another example of chemical injury where he underwent multiple procedures for acid injury. He developed symblepharon and conjunctivalization in the inferior part, shortening of the fornices, as you can see here. Here we used donut-shaped, AMG, because we didn't want to touch the central area. So, and almost all the slat pieces were arranged much closer to the area where there was more of a limbal stem cell deficiency, and you can see a post-operative outcomes. These would not come in couple of weeks. It would take few weeks to few months for the post-operative results. So you have to convince these patients and counsel them very well. This is an extreme case of LSCD, 360 degree with total conjunctivalization and a little bit of central scarring. To our amazement, even the central area looked much better. But now with the availability of anterior segment OCT, you can pre-decide what is the involvement of the corneal tissue before planning the surgical procedure. This was another case who was he sustained chemical injury almost 30 years back with a disinfectant powder, and he was having recurrent. Shall I conclude? I think I'll conclude in a couple of slides only. And these are the post-op results. Sometimes if you have a central corneal scar, maybe you have to follow it up with, after the slat, you can take these patients for PK or DALK, and the results are very good. One of the publication from RP Center talks about it, that 72.72% patients had good visual outcome, and success rate was almost 54% in these cases. And this is my last slide. As you can see here, this patient underwent multiple reconstructions. You can see the lids also. The lids underwent reconstruction, the face, the nose. As you can see here, I've been following him up from 2009, a very severe chemical injury from a very big company in Gujarat. And you can see that many a times the reconstruction or rehab would go on lifelong for such patients. With this, I would like to summarize: one should choose the surgical procedure carefully for individual case and its needs. Proper counseling of the outcomes and long-term results will lead to satisfactory results for both patient and the surgeon. Thank you very much for the kind attention, and I would like to invite you to CARACON 2023, which will be held at Chandigarh in December 8th, 9th and 10th. Thank you for the kind patient hearing.
Okay, thank